Welcome back to the Deep Dive, the place where we distill the most essential, high-stakes clinical knowledge into actionable insight.
Hello again.
Today, we are undertaking a massive and absolutely critical deep dive, the comprehensive management of patients living with diabetes.
We are.
And our source material is foundational. We've got a key chapter pulled straight from the medical surgical nursing playbook, Brunner and Setterks.
That's right. If you're preparing for your clinical rotation or, maybe you're a clinician who just needs a rapid, reliable review of the gold standard for diabetes care, this is your deep dive.
Yeah.
Our mission is to move step by step through the core concepts from the shocking epidemiology to the detailed pharmacologic regimens and, most importantly, the life-saving nursing interventions.
Okay, let's unpack this right away. Before we even talk about the patient, we have to define the fundamental metabolic breakdown. What defines this entire group of disease processes?
At its heart, diabetes is a constellation of metabolic diseases characterized by persistent, chronic hyperglycemia, so abnormally high glucose levels in the blood.
Right, high blood sugar.
Exactly. And this elevation happens because of defects in the body's ability to produce the key hormone, insulin, or its ability to utilize that insulin effectively, or sometimes a combination of both problems.
And we're going to be dropping key clinical terms repeatedly, so let's make sure we nail down the glossary now so we all know what kind of emergency we're dealing with later.
Excellent idea. Beyond just insulin and hyperglycemia, we're really going to focus on 4 key concepts. First, the 2 big acute emergencies.
Okay.
You've got diabetic ketoacidosis, or DKA, which you typically see in type 1. That involves a severe insulin deficiency that leads to the formation of these highly acidic ketone bodies.
And that's metabolic acidosis.
A severe metabolic acidosis. Then second, you have hyperglycemic hyperosmolar syndrome, or HHS. That's more common in type 2, and it's defined by extreme hyperglycemia and dehydration, but, and this is key, without that corresponding acidosis.
That distinction, acidosis or no acidosis, is going to be absolutely crucial for management, right?
It is. It changes everything.
Yeah.
Then we have prediabetes, which includes impaired fasting glucose, IFG, or impaired glucose tolerance, IGT.
So this is the warning stage?
Exactly. It's that intermediate stage where blood glucose is elevated, but it's not yet high enough to be a full diagnosis of diabetes.
Okay. And the last one, the long-term metric.
Right. And finally, the long-term metric we rely on, glycated hemoglobin, or HbA1c. You have to remember, this isn't a snapshot of today's sugar. It's a vital measure of average glucose control over the 120-day lifespan of a red blood cell.
Let's start with the scale of this problem, because the source material is, well, it's emphatic. Diabetes is an epidemic that fundamentally alters the landscape of healthcare.
It's really hard to overstate the numbers. We are talking about over 34.1 million adults in the U.S. having diabetes.
That's huge.
It is. But what's perhaps even more alarming is that almost 1/3 of those cases are undiagnosed. They're just floating under the radar. And the projections are, frankly, terrifying. By 2050, it's estimated that 1 in every 3 adults in the U.S. could have diabetes.
That economic impact must be massive, too.
It's staggering. Based on 2020 data, we're looking at over $237 billion annually in direct medical costs.
Billion with a B.
With a B. Plus an estimated $90 billion lost in productivity. But the real devastating cost isn't human suffering. The source is very clear about this.
What are the big ones?
Diabetes is the leading cause of non-traumatic amputations, the leading cause of end-stage kidney disease, ESKD, in the U.S., and the leading cause of new blindness in adults aged 18 to 64. It's also the 7th leading cause of death overall.
So given that scope, the nurse's primary role in screening for risk factors becomes absolutely vital. What should we be scanning for immediately in a patient history?
This comes straight from that foundational screening checklist, chart 46-1 in the book. And the risks are varied. Age matters, for one.
Right.
Typically, type 2 risk increases significantly after age 30, though type 1 is often diagnosed, much younger, before that age.
And obesity is a huge one.
A major trigger, defined specifically as a BMI greater than 30. We also look for established cardiovascular risk factors like hypertension, or specific dyslipidemia profiles, like a low HDL cholesterol, so that's less than 35, or high triglycerides, over 250.
And genetics plays a role, of course.
Absolutely. A family history, a parent or sibling with diabetes, definitely increases risk. And we have to acknowledge the tragic reality that certain racial and ethnic groups are disproportionately affected.
Who are they?
This includes African Americans, Hispanic Americans, Native Americans, Asian Americans, and Pacific Islanders.
Okay, before we move to the classifications, we really must establish the normal system. I think we need to understand that push and pull mechanism between the pancreas's two key hormones, insulin and glucagon.
Right. Think of insulin as the ultimate anabolic or, the storage hormone. It's secreted by the pancreatic beta cells when blood glucose is high, usually right after a meal.
And it has a few different jobs.
It has several key roles, yeah.
Yeah.
It acts like a transport key, basically, facilitating the movement of glucose into the cells for immediate energy. It signals the liver and muscle cells to store glucose as glycogen.
And crucially, it tells the liver to stop making its own sugar.
Exactly. It signals the liver to halt the release of its own glucose stores. It's the gatekeeper that promotes storage of fat and protein, and, it inhibits the breakdown of any stored fuels.
So insulin basically says, we have plenty of fuel now, start saving for later. But what happens when you're fasting, like overnight?
That's where the balance mechanism kicks in. During fasting, the pancreas maintains a low, continuous release of what we call basal insulin, but your body still needs fuel.
Right.
So the alpha cells in the pancreas release glucagon, and glucagon does the opposite of insulin. It stimulates the liver to release its stored glucose. That's a process called glycogenolysis to maintain a stable blood sugar.
And if you keep fasting?
If the fasting continues, the liver switches gears to gluconeogenesis, which is just making new glucose from non-carbohydrate sources, like amino acids. Insulin and glucagon are constantly working against each other to maintain, a normal blood sugar or euglycemia.
Okay. Now that we know the normal function, let's look at the pathology of the two main types. Type 1 diabetes is, well, you called it an autoimmune catastrophe.
It is. Type 1 is the minority, only about 5 to 10% of cases. Its hallmark is the absolute absence of the body's own insulin. And this is caused by an autoimmune process that systematically destroys those pancreatic beta cells.
And we think it has a trigger.
Right. This destruction is usually triggered by a combination of genetic, immunologic, or even environmental factors.
And this pathology is usually pretty rapid, leading to severe hyperglycemia.
Correct. Without insulin, the cells are essentially starving and the gatekeeper is just gone. The glucose from food and the glucose the liver continues to produce remain trapped in the bloodstream,
Which leads to
severe fasting and postprandial hyperglycemia. And since insulin normally puts the brakes on the liver, glycogenolysis and gluconeogenesis just proceed completely unrestrained, dumping even more sugar into the blood.
this unchecked high glucose level leads directly to the classic symptoms, this idea of osmotic diuresis and the DKA risk. Can you walk us through the mechanism of osmotic diuresis?
Absolutely. So when the blood glucose concentration rises above the kidney's maximum reabsorption capacity, we call that the renal threshold, which is usually around 180 to 200 milligdl.
Okay.
Glucose begins to spill into the urine. That's glycosuria. Since glucose is osmotically active, it pulls large amounts of water and electrolytes with it, leading to excessive urination or polyuria.
Which then leads to severe dehydration and thirst.
Exactly, or polydipsia.
And the high risk of DKA, where does that come from?
The DKA risk is tied to the fact that without any insulin, the body has to immediately switch to burning fat for energy.
Right, it's a backup fuel.
It's the only fuel it has. But this unregulated breakdown of fat, or lipolysis, creates these acidic byproducts called ketone bodies. And the accumulation of these acids just overwhelms the body's buffering capacity, leading to severe metabolic acidosis and ultimately DKA.
Okay, let's move on to type 2, which accounts for 90 to 95% of all cases, and it's often linked to obesity and age. The failure here is slower and it's much subtler. What are the dual problems that define type 2?
Type 2 is really a two-pronged attack. First, you have insulin resistance. This is where the target tissue, so your muscle, fat, and liver, become less responsive to insulin signals.
So the key isn't working as well in the lock.
Perfect analogy. And the pancreas initially tries to compensate by hypersecreting insulin. But second, over time, those exhausted beta cells become impaired, and they just can't secrete enough insulin to overcome that resistance.
So there's a relative deficiency, not an absolute one, which is the key distinction when we think about acute complications.
Precisely. And this is a critical clinical nugget. In type 2, enough insulin is usually still present to prevent that massive catastrophic breakdown of fat.
Which is why they don't usually get DKA.
Exactly. That's why DKA is uncommon in type 2, unless they are severely stressed or have a major infection. Instead, their major acute risk is Hyperglycemic Hyperosmolar Syndrome, or HHS.
And because the onset is so insidious, type 2 can go undiagnosed for years, meaning complications may already be advanced when it's finally found.
That's the real danger. The symptoms are often mild: generalized fatigue, irritability, maybe some polyuria and polydipsia, or just nonspecific complaints like blurred vision or skin wounds that just won't heal.
That's easy to ignore.
Very easy.
Yeah.
And because the symptoms are so subtle, type 2 is frequently discovered, incidentally, during routine lab work. And this means that serious long-term damage to the eyes or nerves may have been accumulating silently for years.
We also need to acknowledge the stage right before type 2, prediabetes. This is where we have the biggest opportunity for preventative intervention.
Prediabetes is the warning zone. The blood glucose levels are too high to be normal, but they're not yet high enough for a full diabetes diagnosis. We call it IGT or IFG.
And these patients are at high risk.
Incredibly high risk. Not just for future diabetes, but for cardiovascular disease. But the data on intervention is really powerful.
What does it show?
Lifestyle modification, specifically achieving a weight loss of just 7% or more, has been shown to result in a dramatic 58% lower incidence of future diabetes compared to a placebo.
Wow, that's a huge payoff.
A massive payoff for behavioral change.
Okay, finally, let's touch on gestational diabetes, or GDM.
Yeah.
When does this typically show up, and what is the underlying cause?
GDM is glucose intolerance that develops specifically during pregnancy, usually in the second or third trimester.
And what's causing it?
It's caused by the hormones that are released by the placenta, which create a state of profound insulin resistance, and the management is strict diet and often insulin to protect both the fetus and the mother.
And what about the long-term risk for these women?
It's significant. High-risk women should be screened at their very first prenatal visit, and all others between 24 and 28 weeks. Importantly, 35 to 60% of women who have GDM will eventually develop type 2 diabetes within 10 to 20 years.
So they need regular screening after the baby is born?
Absolutely. They need regular screening postpartum, typically every 3 years.
Okay, before we leave this section, there's one final crucial clinical consideration we can't ignore: the link between diabetes and COVID-19.
Yes. We saw absolutely devastating numbers during the pandemic.
We did.
And the epidemiological data strongly indicates that diabetes, regardless of the type, is a significant risk factor for contracting SARS-CoV-2, for requiring hospitalization, and for experiencing poorer outcomes.
What kind of poorer outcomes?
Well, patients with diabetes who are hospitalized with COVID-19 showed higher rates of intubation and mortality, particularly older patients and those who are already on insulin therapy. It really reinforces why meticulous glucose control is so essential, especially in the inpatient setting.
Okay, so type 1 is the catastrophe, type 2 is the slow burn. If the disease is manifesting, the source material focuses on 3 cardinal signs, the 3 Ps. What are they, and what metabolic process drives each one?
The 3 Ps are the absolute must-knows. First, you have polyuria, which is excessive urination,
Right.
and polydipsia, excessive thirst. And both of those are direct consequences of osmotic diuresis, that high glucose concentration literally pulling water out through the kidneys.
And the third P, which tells us the body is literally starving for energy despite having all this sugar in the blood.
That's polyphagia, or increased appetite. This results because it doesn't matter how much sugar is in the bloodstream, the cells just can't access it because of the lack of insulin action.
So the body thinks it's hungry.
It perceives this cellular starvation as intense hunger, triggering a constant drive to eat.
Beyond the Ps, what are the other common sort of non-specific symptoms that might lead a patient to finally seek care?
Generalized fatigue and weakness are highly common. We often see vision changes, particularly blurred vision, which can fluctuate wildly with glucose levels.
Okay.
Neuropathy can present as tingling or numbness in the hands or feet. And because hyperglycemia impairs the function of white blood cells, patients often present with slow-healing skin wounds, dry skin, or recurrent infections like frequent yeast infections or UTIs.
So if a patient presents with those signs, how do we officially move from suspicion to diagnosis? The ADA criteria, which is chart 46-2 in the text, provide 4 hard and fast metrics.
Yeah, the ADA criteria are the diagnostic gold standard. It only takes one of the 4 to confirm the diagnosis, although in the absence of an acute crisis, confirmation by repeat testing on a separate day is required.
Okay, give us the first criterion.
Criterion 1. A casual or random plasma glucose level that's equal to or greater than 200 milligdl, plus the presence of classic symptoms.
The 3 Ps, or unexplained weight loss.
Exactly.
Okay, criterion 2, the standard fasting test.
The fasting plasma glucose, or FPG. This requires no caloric intake for at least 8 hours, and the number is equal to or greater than 126 milligdl.
And criterion 3, which I gather is used less often routinely.
Right, that's the 2-hour postload glucose reading, which has to be equal to or greater than 200 milligdl during an oral glucose tolerance test, or OGTT, using a 75-gram glucose load.
And finally, the indispensable HbA1c.
Criterion 4. Hemoglobin A1c equal to or greater than 6.5%. And that provides that powerful retrospective evidence of poor control over the last few months.
Before we move on, we have to pause for a crucial gerontologic consideration. Diagnosing this in older adults is tricky because their symptoms can be really misleading.
This is a major clinical caveat. Older patients may not exhibit the classic 3Ps, or their symptoms might be really nonspecific, like just fatigue or confusion.
And there's an issue with their kidneys, too.
Yes. Even more importantly, older adults typically have a higher renal threshold for glucose. This means glucose doesn't spill into the urine as readily as it does in younger patients.
So urine testing is useless.
It is. Therefore, relying on urine testing for glucose is ineffective in diagnosis. We have to use a fasting plasma glucose, or the OGTT.
Once the diagnosis is established, the nurse's job transitions from diagnosis to prevention. The comprehensive assessment in Chart 46.3 is really the blueprint for all ongoing care, designed to detect complications early.
This ongoing assessment is a lifetime plan. We start with a meticulous history. We ask about the frequency and severity of current hypo or hyperglycemia, but we really focus on the status of chronic complications.
Eyes, kidneys, nerves.
Exactly. Eyes, kidneys, nerve, cardiac, and GI, or sexual function. And we have to inquire deeply about their adherence to the entire regimen diet, exercise, and medication, plus their use of tobacco and alcohol.
And the physical exam is highly targeted, particularly on the lower extremities.
The physical exam has to include sitting and standing blood pressure checks to screen for orthostatic hypotension. We check BMI, perform a fundoscopic exam to check the retina, and then move to the non-negotiable part, the detailed foot examination.
What does that include?
This includes assessing pedal pulses, looking meticulously for any lesions or signs of infection, and using a monofilament to test for the critical loss of protective sensation. We also have to check insulin injection sites for lepidystrophy.
And the essential lab work.
We need the HbA1c, a fasting lipid profile, serum creatinine, a urinalysis, and that early warning indicator of kidney damage, the test for microalbuminuria. An ECG is also usually recommended.
The nurse doesn't have to be the expert in everything, but they must know when to call for backup. What are the essential referrals?
Right. The assessment wraps up with ensuring the patient is linked with the specialists they need to prevent long-term damage.
Like
Ophthalmologist for the eyes, a podiatrist for dedicated foot care, and critically, a registered dietitian for medical nutrition therapy, MNT, and a certified diabetes educator. That MNT referral is just as vital as the eye exam.
Okay, we've established the diagnosis and the patient profile. Now we execute the plan. The overarching goal is to normalize insulin activity and blood glucose to prevent those devastating long-term complications. And this goal is entirely driven by the results of the DCCT trial.
Yeah, that trial from the 1990s fundamentally changed diabetes care. It proved that intensive glucose control, so aiming for an HbA1c below 7%, resulted in a dramatic reduction in the development and progression of retinopathy, nephropathy, and neuropathy.
So there's a tangible payoff.
A tangible, life-altering payoff.
Management relies on 5 interwoven components. We'll cover the first 3 now: nutritional therapy, exercise, and monitoring. Let's start with MNT.
MNT is the bedrock of management. It has 3 core objectives: controlling caloric intake for a healthy body weight, normalizing blood glucose levels, and controlling lipids and blood pressure to mitigate cardiovascular risk.
And for the vast majority of patients with type 2 and obesity, weight loss is the primary therapeutic goal.
It is the single most powerful tool. Losing just 5 to 10% of total body weight can profoundly improve glycemic control, often reducing or entirely eliminating the need for oral medications.
And meal timing is important.
The nurse must emphasize pacing food intake. Patients should never skip meals, as this can lead to both hypoglycemia and then compensatory overeating. Pacing decreases the immediate demand on the beta cells.
What are the current distribution recommendations for macronutrients?
The ADA and AED recommendations balance them out. Carbohydrates should make up about 50 to 60% of total calories, ideally sourced from nutrient-dense whole grains.
And fats.
Total fat should be under 30%, with saturated fats limited to 10%, and cholesterol below 300 milligrams a day. Protein is about 10 to 20%, though a slight reduction may be necessary if the patient is showing early signs of kidney disease.
And you mentioned the importance of fiber.
Fiber is critical. We aim for at least 28 grams daily. Soluble fiber, found in things like oats and beans, helps slow gastric emptying and delays glucose absorption.
And insoluble fiber.
Insoluble fiber, like in whole grains, aids satiety.
Yeah.
But the nurse has to stress two practical teaching points. Increase fiber gradually and make sure the patient is drinking adequate fluids to prevent uncomfortable GI symptoms like gas or constipation.
Let's discuss the meal planning tools that are used to make this abstract diet plan actionable. We have exchange lists, carbohydrate counting, and the glycemic index.
Okay, so the exchange lists, which is what's in Table 46.2, are useful for maintaining consistency. They group foods like bread starch, milk, or meat, where foods within a group are interchangeable based on similar caloric and nutrient profiles.
So it provides variety.
Exactly. It provides variety while ensuring the regimen stays consistent.
But carbohydrate counting provides the flexibility that's required for intensive insulin regimens.
Correct. Carb counting is the modern precision method. Since carbohydrates are the primary nutrient that gets converted to glucose, 100% of them, the patient focuses solely on them.
And one serving is how much?
One carbohydrate serving is defined as 15 grams. This allows them to calculate their precise insulin bolus based on a predetermined carbohydrate ratio. The caveat is that while it offers flexibility, patients have to remain mindful of total caloric intake to prevent weight gain.
And the glycemic index, or GI?
GI is a measure of how quickly a food raises blood glucose compared to pure glucose. While it's sometimes controversial regarding long-term outcomes, the guidelines are useful.
For instance,
Combine starches with protein or fat to slow absorption. Eat foods raw or whole, which lowers the GI, and opt for whole fruit over juice.
moving to other dietary concerns, alcohol presents a significant metabolic risk, especially for insulin users.
Moderation is generally accepted, so 1 drink for women, 2 for men. But the clinical alert is hypoglycemia.
How so?
Alcohol inhibits gluconeogenesis, that's the liver's ability to make new glucose. This can lead to severe, delayed hypoglycemia hours after drinking.
So what's the safety rule?
The safety rule is absolute. The patient must never consume alcohol on an empty stomach and must always consume food along with the drink.
And we have to talk about the warning on misleading labels, which we must teach patients to overcome.
Yes. The nurse has to caution that terms like sugarless or dietetic do not mean calorie or carbohydrate-free. These foods often contain nutritive sweeteners like sorbitol or xylitol, which still contribute calories, or they may be high in saturated fats.
So they have to read the fine print.
Patients have to read the nutrition facts panel, not just the front label.
Okay, exercise is the second critical foundation. Beyond general health benefits, what specific effects does it have on glucose metabolism?
Exercise is, insulin's best friend. It immediately lowers blood glucose by increasing the cell's uptake of glucose and improving insulin utilization at the tissue level.
And for cardiovascular health?
It powerfully improves cardiovascular health by increasing HDL, the good cholesterol, and decreasing triglycerides. It also aids in weight loss and stress management. For type 2 patients, resistance training, which is recommended twice a week, is vital for building lean muscle mass, which raises the resting metabolic rate.
The general considerations from Chart 46-4 are really non-negotiable for safety.
Right. We counsel patients to exercise 3 times per week, aiming for no more than 2 consecutive rest days. Consistency and timing is key, preferably timing exercise to coincide with peak blood glucose levels.
And safety precautions.
Safety precautions include wearing appropriate protective footwear, avoiding temperature extremes, and, most critically, performing a meticulous daily foot inspection if peripheral neuropathy is present.
Now let's inject some clinical gravity here.
Yeah.
The precautions are life-saving. There are 2 major risks. First, the condition where the patient must never exercise.
This is the cardinal rule. Do not exercise if your blood glucose is greater than 250 milli-GDL and ketones are present in the urine.
Why not?
This signals a severe insulin deficit. Exercising in this state is dangerous because the physical stress releases counter-regulatory hormones, glucagon, catecholamines, which signal the liver to dump even more glucose into the blood. This results in an exponential rise in blood sugar and can actually precipitate DKA.
And the second major risk, particularly for insulin users, hypoglycemia during or after exercise.
Right. Since the patient is using exogenous insulin, their body can't perform the normal physiological decrease in insulin release that happens during activity. This really heightens the risk.
So what's the prevention?
To prevent this, patients on insulin must consume a 15-gram carbohydrate snack, like a fruit exchange, before beginning moderate exercise. They have to monitor their blood glucose frequently, before, during, and after. If the exercise is long or strenuous, they may need an extra snack at the end or even at bedtime to prevent delayed post-exercise hypoglycemia.
Monitoring is the third foundation, the feedback loop that dictates the entire regimen. SMBG, self-monitoring of blood glucose, is the absolute cornerstone.
SMBG empowers the patient to individualize their treatment. It allows them to instantly detect and prevent dangerous swings in glucose.
And who is it mandatory for?
It is mandatory for anyone on intensive insulin therapy, so 4 or more daily injections or an insulin pump, and also for pregnant patients, those with unstable diabetes, or those prone to hypoglycemia unawareness.
What's the recommended frequency?
For intensive insulin users, the recommended frequency is 2 to 4 times daily, usually before meals and at bedtime. If they are actively adjusting mealtime boluses, it should be at least 3 times daily before meals.
And for non-insulin users?
For non-insulin users, testing 2 to 3 times a week, including a 2-hour postprandial check, is recommended, supplemented by testing whenever symptoms suggest there might be a problem.
And the nurse has a huge role here because technical errors are, well, they're rampant.
Oh yes, the nurse must observe and correct the patient's technique every 6 to 12 months. Common errors include not getting a large enough blood drop, using damaged or expired strips, or improper calibration settings. Accuracy is everything.
Let's discuss the more advanced tool, continuous glucose monitoring, or CGM.
CGM is a major advancement. It's that little sensor in figure 46-2. It uses a subcutaneous sensor, typically replaced every 7 to 14 days, to transmit real-time glucose readings.
And how is it useful?
It's incredibly valuable for identifying patterns and minimizing peaks and valleys, especially in type 1. The caveat is that these readings often lag a little bit behind actual blood glucose, so they are generally used for pattern recognition, not for making immediate, precise insulin dosing decisions.
The true measure of long-term success is the HbA1c. Explain the difference again. SMBG is today's snapshot. A1c is the past 3 ones.
That's the key distinction. SMBG is a moment-in-time snapshot. HbA1c measures the attachment of glucose to hemoglobin over the life of the red blood cell, which is about 120 days.
So it gives you the average.
It gives us the average level of control over the past 3 months. The ADA goal for most patients is less than 7%. If a patient reports great daily SMBG readings but their A1C is high, it tells us they're experiencing significant unmonitored glucose elevations, possibly overnight or during stress.
Finally, ketone testing. This signals acute danger for type 1 patients. When is it mandatory for them to test?
Ketones are the alarm bell. They indicate the body has switched to fat metabolism due to severe insulin deficiency, putting the patient at DKA risk.
So when do they test?
Patients must test for urine or blood ketones whenever their blood glucose is persistently elevated, greater than 240 mg/dL for 2 consecutive periods, or during any illness, acute stress, or pregnancy with pre-existing diabetes.
We've covered MNT, exercise, and monitoring. Now for the fourth pillar, pharmacologic therapy. Insulin is required for life in type 1 and often necessary for type 2 patients temporarily during surgery or illness, or long-term if oral agents fail.
Right. And the principle of effective insulin therapy is that the patient's dosage is dynamic. It has to be determined precisely by their blood glucose levels and their daily activity.
Table 46.3 in the textbook is critical because meal timing hinges on the time course of action of these insulins. Let's compare the action curves. We need to know onset, peak, and duration.
Okay, let's start with the quickest. Rapid-acting insulins. These are Lispro, Aspart, Glulisine, even the inhaled one, Afrezza.
And their onset.
They have a near-immediate onset, typically 5 to 30 minutes, and a short duration. The patient must be taught to have food in front of them, ready to eat, within 5 to 15 minutes of injection.
And they always need a long-acting insulin with them.
Always. They require a complementary long-acting insulin to provide basal coverage.
Okay, next up, short-acting or regular insulin.
Short-acting or regular insulin is slightly slower, with an onset of 30 to 60 minutes. It's given about 15 minutes before the meal. Clinically, this is the only preparation that can be safely administered intravenously.
Which makes it the insulin of choice in emergencies like DKA.
Exactly.
Okay, intermediate acting, NPH, used to be the primary basal insulin.
Right. NPH is cloudy, has an onset of 1 to 1.5 hours, and a long, broad peak, often up to 12 hours. It functions as a basal insulin, but often requires split doses to cover 24 hours.
And you have to time food with it.
Given its long peak, the patient must coordinate a snack or meal around both its onset and its peak to prevent hypoglycemia.
And the modern basal agents. The long-acting peakless insulins.
Largine and Datamir. Their onset is delayed about 3 to 6 hours, and they are absorbed over 24 hours, providing a constant, stable, peakless basal dose. This mimics the body's natural basal insulin release much better than NPH.
And there's a huge safety note for nurses here.
A crucial safety note. Glargine is acidic and cannot be mixed with any other insulin type in the same syringe. And consistency and timing, usually once a day, is key.
The source contrasts conventional versus intensive regimens, which is laid out in Table 46-4. How do we determine which is appropriate for a patient?
Well, the conventional regimen is simplified. 1 or 2 injections daily, often a pre-mixed, short intermediate dose. It requires a rigid, fixed schedule for meals and activity and offers minimal flexibility.
So who is that for?
It's best for patients who are unwilling or unable to manage that complexity, the terminally ill, the frail elderly, or those with significant cognitive deficits.
The intensive regimen, on the other hand, is the standard of care for optimal complication prevention.
Absolutely. Intensive therapy, so 3 to 4 daily injections, or a pump aims to mimic the normal dynamic pancreas. It allows patients to change doses based on carb counting, activity, or stress.
But it has a major risk.
It dramatically reduces complications, but critically, it increases the risk of severe hypoglycemia threefold. It requires a highly motivated, highly educated patient.
Let's discuss the complications specific to the medication itself. We mentioned lipodystrophy earlier, those fibrofatty masses.
Right. Lipodystrophy is the localized reaction at the injection site. And lipohypertrophy, that's the lumpy fibrofatty mass caused by repeated use of the same spot, is the most common issue.
And what's the danger of injecting into those spots?
Injecting into these areas severely delays and inconsistently absorbs the insulin, causing wild glucose swings. Strict, consistent rotation of sites is the mandatory teaching point to prevent this.
How should they rotate?
We recommend using all available sites within one anatomical area, like the abdomen, before moving to another area, rather than jumping from abdomen to arm to thigh constantly.
This brings us to the crucial differential diagnosis for morning hyperglycemia, which is chart 46-5. Waking up with high blood sugar requires a 3 a.m. blood glucose test to solve the mystery. What are the 3 possibilities, and what is the key difference in treatment?
This is a high-yield diagnostic point. The 3 a.m. test differentiates the cause. First, you have insulin waning.
What's that?
The glucose progressively rises from bedtime until morning. It just means the evening insulin is wearing off. Treatment: increase the evening dose of intermediate or long-acting insulin.
Okay, second possibility.
Second is the dawn phenomenon. Glucose is normal until about 3 a.m., and then it sharply rises. This is due to the natural nocturnal surge of growth hormone and cortisol. Treatment: move the timing of the evening intermediate-acting insulin dose from dinner time to bedtime.
And the third, the trickiest one, the Somogyi effect.
Right. The Somogyi effect is when glucose is normal or high at bedtime, but it dips into hypoglycemia around 2 to 3 a.m. This triggers counter-regulatory hormones, which then cause a rebound high glucose in the morning.
Wait, so if the patient is high in the morning due to the Somogyi effect, the treatment is completely counterintuitive, isn't it?
Precisely. If you miss that 3 a.m. low, you might mistakenly increase the insulin dose, which would just exacerbate the nocturnal low and the morning rebound.
So what's the treatment?
Treatment: decrease the evening intermediate-acting insulin dose or provide a larger bedtime snack to prevent that initial dip. The 3 a.m. test is essential because the treatment for waning and dawn requires more insulin, but the treatment for Somogyi requires less.
The delivery methods are moving beyond the standard syringe. Insulin pens are pretty convenient.
Pens use pre-filled cartridges, delivering insulin in set increments. They are fantastic for travel, convenience, and for patients whose vision or dexterity makes drawing up precise doses from a vial difficult.
And the insulin pump, or CSII, offers the most flexibility but carries the highest risk if the patient is not compliant.
Right, the pump provides continuous subcutaneous insulin infusion, and it only uses rapid-acting insulin. It delivers a constant, programmed basal rate and requires the patient to manually input carb counts for pre-meal boluses.
And what's the primary risk?
The primary risk is DKA. Since only rapid-acting insulin is used, any occlusion in the tubing or catheter immediately leaves the patient without any basal insulin whatsoever, which can lead rapidly to ketosis. Pump users have to be highly motivated, highly educated, and committed to meticulous SMBG or CGM.
Okay, let's talk about oral agents. These are the standard first line for type 2, used in addition to MNT and exercise. We need to compare the key classes from Table 46-5, focusing on the single most important clinical alert for each.
Okay, let's start with the cornerstone. Big one-ides, specifically metformin. Its primary action is to inhibit the liver from producing glucose and to increase tissue sensitivity to insulin.
And what's the crucial clinical alert here?
The risk of lactic acidosis or acute kidney injury if the patient undergoes a procedure requiring iodinated contrast material, like a CT scan. Metformin must be stopped 48 hours prior to and 48 hours following the use of contrast agent or until renal function is confirmed as normal.
Next, the older but still very common sulfonylurias like glipizide or glyburide.
Sulfonylurias are secretagogues. They stimulate the beta cells to secrete insulin. Their key risk is hypoglycemia because they force the pancreas to release insulin regardless of the glucose level, and they can cause weight gain.
So you have to be careful with certain populations.
You have to use them cautiously in older adults and those with renal impairment, as the drug's half-life can be prolonged.
How about the drugs that affect absorption, like alpha-glucosidase inhibitors, such as acarbose?
The carbose works by delaying the breakdown and absorption of complex carbohydrates in the GI tract. This means the patient must take the medication with the first bite of food to be effective.
And there's a key point about treating hypoglycemia if they're on this drug.
Yes, a high-yield nugget. If the patient develops hypoglycemia, it has to be treated with pure glucose, like glucose tablets, not simple table sugar or sucrose, because acarbose inhibits the breakdown of sucrose into absorbable glucose.
Okay, thiazolidinediones, or TZDs, like pioglitazone, sensitize peripheral tissues to insulin.
Right. TZDs improve tissue response, but they carry risks of weight gain and edema and require monitoring of liver function tests due to possible liver dysfunction.
Moving to the newer, generally safer classes, DPP-4 and SGLT2 inhibitors.
DPP-4 inhibitors like sitagliptin amplify the effect of the body's natural incretin hormones, which increases insulin release and decreases glucagon release in a glucose-dependent way.
Meaning a lower risk of hypoglycemia.
Exactly, a much lower risk of hypoglycemia, and they're typically given once daily.
And SGLT2 inhibitors.
SGLT2 inhibitors like dapagliflozin work entirely outside the pancreas. They block the kidney's ability to reabsorb glucose, causing it to be excreted in the urine. The major clinical alert here is to monitor for genital and urinary tract infections, as that high glucose urine creates an ideal breeding ground for bacteria.
Finally, the newer injectables like GLP-1 agonists.
GLP-1 agonists like liraglutide also stimulate glucose-dependent insulin secretion, but importantly, they also slow gastric emptying. This is often associated with satiety and weight loss.
We've established the treatment goals, but none of this works unless the nurse teaches the patient how to apply it. Let's shift focus entirely to that crucial educational role, beginning with the challenge of glucose management in the stressful hospital setting.
Yeah, hyperglycemia in the hospital prolonged stays, increases wound infection risk, and raises mortality rates. The targets are strict. Blood glucose should be maintained between 140 and 180 milligdl.
And insulin is preferred over orals.
Yes, insulin, either IV or subcutaneous, is the preferred method over oral agents. The key nursing responsibility is the meticulous timing of everything: blood sugar checks, meal trays, and insulin administration to prevent hypoglycemia.
The nurse is the primary educator, and the source emphasizes that education is a lifetime process, balancing all the components.
The problem is the short length of hospital stays. The nurse has to assess the patient's readiness to learn, recognizing that they may be cycling through the grieving stages, shock, denial, anger.
But some things have to be taught before they leave.
Despite any cognitive deficits or denial, the nurse must ensure basic, essential skills are taught before discharge.
Chart 46-6 outlines the basic skills every new patient must acquire. What are the fundamentals?
They must know the basic pathophysiology, what diabetes is, how food, stress, and insulin affect it. They have to master the treatment modalities, how to administer their medication, basic meal planning, and monitoring technique.
And what to do in a crisis.
They absolutely must be able to recognize, treat, and prevent acute complications, both hypo and hyperglycemia. And finally, the pragmatic information: where to store supplies, where to buy them, and when to call the provider.
This requires hands-on teaching. Let's start with insulin storage. It sounds simple, but errors here can render the insulin completely inactive.
Right. Vials that are not in use should be refrigerated. The vial that's currently in use can be kept at room temperature for up to 1 month. This prevents the burning or irritation of a cold injection.
And temperature is key.
Crucially, the patient must avoid temperature extremes. No freezing, no direct sun, no heat. The nurse also has to teach them to inspect intermediate-acting insulins, like NPH for flocculation. That's a frosted, whitish coating inside the bottle, which indicates the insulin is inactive and should be discarded.
And the high-stakes procedure: mixing insulins. This is where cross-contamination can happen.
Yes. When mixing rapid or short-acting with longer-acting insulins, the rule is consistency, and the ADA recommends drawing up the regular or clear insulin first.
What's the safety rule?
The safety rule is simple: Never inject cloudy or intermediate insulin into a clear or short-rapid vial. This contaminates the clear insulin and changes its predictable action curve.
Injection sites matter greatly for consistent absorption rates.
We have four main anatomical areas: abdomen, upper arms, thighs, and hips. Absorption is fastest in the abdomen.
So how should they rotate?
To maintain consistency, the patient should be taught to rotate sites within one anatomic area. For example, rotating injections around the entire abdomen before moving to a different site entirely. This prevents inconsistent absorption and lipodystrophy.
And the essential steps for the injection itself, from chart 46 to 7.
The steps are clear. Stabilize the skin, either by pinching a large area or spreading it taut. Insert the needle straight in at 90 degrees or 45 degrees for very thin patients. Push the plunger. Withdraw the needle.
And what about aspiration?
The critical teaching point here is aspiration or pulling back on the plunger is not necessary. This practice has been safely abandoned in current guidelines.
How does the nurse evaluate that the patient has truly learned this life skill? That's in chart 4068.
We have to confirm they can successfully draw up and mix the insulin, demonstrate proper rotation, know the onset and peak of their specific insulin, and crucially integrate the injection into their daily life schedule. The mnemonic TIE test insulin, EAT, is a helpful mental cue for timing.
Finally, we cannot overstate the importance of hypoglycemia education. This is the life-saving skill.
The patient and their family must know the signs and the immediate treatment protocol. Mild signs are adrenergic, so sweating, tremor, nervousness, hunger. Moderate signs are CNS-related, inability to concentrate, confusion, slurred speech.
And the treatment is immediate.
Immediate. 15 to 20 grams of a fast-acting concentrated carbohydrate, like glucose tablets or 4 ounces juice. And they must be warned against high-fat snacks like cookies or chocolate, as fat slows gastric emptying and delays glucose absorption.
And for severe hypoglycemia when the patient is unconscious.
Families must be trained to administer glucagon 1 milligram, either subcutaneously or IM. Since nausea and vomiting are common after glucagon, they have to turn the patient on their side to prevent dangerous aspiration while waiting for emergency services.
And in the hospital?
In the hospital, the immediate treatment is 25 to 50 milliliters of D50W IV, and you have to ensure IV patency because this hypertonic solution is highly irritating to the veins.
Now we shift our tone to reflect the gravity of the situation. We're discussing the 3 acute, life-threatening complications: hypoglycemia, DKA, and HHS.
Right. Hypoglycemia is a blood glucose below 70 milligdl, and it's caused by a mismatch: too much insulin, too little food, or excessive exercise. It usually occurs at insulin peak times or just before a meal.
We must highlight the danger of hypoglycemia unawareness.
This is a terrifying complication where the patient lacks the normal warning signs: the sweating, the shaking, the hunger, often due to autonomic neuropathy or medications like beta blockers.
And without those warnings?
Without those adrenergic warnings, the patient progresses rapidly and suddenly to severe CNS impairment, like confusion or seizures. Frequent SMBG is the only defense.
And the geriatric population is at a massive risk for this entire syndrome.
Absolutely. Older adults may live alone, leading to unrecognized symptoms. Decreased kidney function prolongs the half-life of oral agents, increasing their duration of action. And furthermore, hypoglycemia in the elderly carries the massive secondary risk of falls and hip fractures.
So you have to be extra careful.
We have to emphasize careful assessment and simplified devices for this group.
Okay, let's move to Diabetic Ketoacidosis, or DKA. This is the major acute emergency of type 1. It is defined by the absence or severe deficit of insulin, leading to 3 massive problems: hyperglycemia, dehydration, and acidosis.
And the causes are crucial for prevention. Decreased or missed insulin doses, or physical stress, especially illness or infection, which releases counter-regulatory hormones that increase insulin resistance and glucose production.
The clinical manifestations of DKA are very distinctive. What are the key physical signs a nurse should be scanning for during a rapid triage?
Well, besides the signs of volume depletion like orthostatic hypotension and a weak rapid pulse, the hallmarks of acidosis are GI symptoms like anorexia, nausea, vomiting, abdominal pain.
And the breath and breathing pattern.
Exactly. The characteristic fruity, acetone breath from the ketones, and mmol respirations, those deep, non-labored breaths. That's the body frantically trying to blow off CO2 to compensate for the metabolic acidosis. Diagnosis involves a blood glucose, usually between 250 and 800, a low pH, and low serum bicarb.
Prevention is essential. The sick day rules from chart 46 to 9 are non-negotiable patient education. What is the rule the patient is most tempted to break?
They are most tempted to break the single most important rule: Never eliminate insulin doses, even if you are not eating. An illness increases glucose levels.
So what should they do?
They have to test their glucose and ketones every 3 to 4 hours, take supplemental, rapid, or regular insulin doses if needed, substitute soft, carbohydrate-containing foods, and drink fluids every half hour to an hour to prevent dehydration.
Let's discuss the hierarchy of management, because triage and priority are everything in DKA. Priority 1, rehydration.
Rehydration is the engine that drives everything else. Until tissue perfusion is restored, insulin won't work effectively, and glucose excretion is limited. We start with 0.9% normal saline at a rapid rate 0.5 to 1 liter per hour.
And then there's a critical transition point.
Yes, the critical transition occurs when the blood glucose drops to 300 milligdl or less. At this point, we have to switch the IV fluid to D5W, dextrose 5% in water, to prevent a precipitous drop in glucose and hypoglycemia while still maintaining that fluid infusion.
Priority 2, electrolyte restoration, particularly potassium.
Potassium is complex and dangerous. The initial K+ level might look high because of the acidosis, but it will plummet rapidly once we start rehydration and insulin, which drives potassium back into the cells.
So when do you start replacing it?
Potassium replacement must begin once levels drop to normal, even if it was initially high, provided the patient has adequate urinary output. We monitor ECGs and K+ levels every 2 to 4 hours because dysrhythmias are a very high risk.
Priority 3, reversing acidosis with insulin.
This is achieved via a continuous low-rate IV drip of regular insulin. And here's a crucial procedural alert. The nurse has to flush the first 50 millirol of insulin solution through the IV tubing and discard it because insulin adheres to the plastic and the initial dose would be inconsistent.
And you don't stop the drip just because the glucose is normal.
Right. The insulin drip must not be stopped when the blood glucose normalizes. Instead, we increase the dextrose concentration in the IV fluids to prevent hypoglycemia, and the drip continues until the acidosis is chemically corrected.
Now for HHS, the crisis most common in older adults with type 2. If DKA is the acute crisis of insulin absence, HHS is the crisis of extreme dehydration and hyperosmolality caused by relative insulin deficiency. And the key difference is the lack of severe ketosis.
That's the high-yield diagnostic point you get from Table 46.6. In HHS, there's enough insulin to prevent lipolysis and thus prevent ketosis and acidosis. But the hyperglycemia is extreme, typically 600 milligdl or greater.
And that causes massive dehydration.
Massive osmotic diuresis over days or weeks, leading to extreme dehydration, hypernatremia, and a serum osmolality over 320.
And the clinical presentation is dominated by neurological deficits, right?
Yes. Due to the profound cerebral dehydration from that high osmolality, patients often present with severe altered consciousness, seizures, or focal deficits like hemiparesis. But the arterial pH and bicarb are typically normal.
The management follows a similar path but requires extreme caution in that older, fragile patient.
The management priorities are the same: aggressive fluid replacement, followed by potassium replacement, and then a continuous low-rate insulin infusion. However, we have to be exquisitely cautious in older patients for signs of fluid overload monitoring lung sounds, JVD, and arrhythmias.
And they might not need insulin long-term.
A fascinating difference is that many HHS patients may not require insulin after the acute crisis resolves, often returning to diet and oral agents.
The nursing management for these crises is high acuity. What are the key hourly assessment priorities that cannot be missed?
Hourly monitoring is essential. Vital signs, INO, fluid status, and breath sounds. And critically, hourly neurological checks. We have to monitor for the most feared complication during correction: cerebral edema.
Which is prevented by?
Prevented by ensuring the blood glucose is reduced gradually. We monitor potassium, sodium, BUN, and creatinine very closely. The goals center on rapid fluid and electrolyte balance, reduce anxiety, and, once they're stable, a thorough re-education to prevent this from ever recurring.
If the acute complications are about surviving today, the long-term complications are about surviving the next 20 years. Chronic uncontrolled hyperglycemia affects nearly every organ system, typically appearing 5 to 10 years after diagnosis in type 1, but often it's already present at diagnosis in type 2.
And the risk factors for these complications are clear: increased blood glucose levels and hypertension. We categorize them as macrovascular, microvascular, and neuropathy.
Let's start with macrovascular complications. These stem from accelerated atherosclerosis, the thickening, sclerosis, and plaque occlusion of large vessels. What are the three main areas of attack?
First is coronary artery disease, or CAD. Myocardial infarction is 2 to 3 times more common, And the chilling fact here is the increased occurrence of silent MIs, asymptomatic ischemia, due to autonomic neuropathy masking the classic chest pain symptoms. Second is cerebrovascular disease, or CVD. Patients have twice the risk of stroke or a TIA, and again, a key clinical alert. Stroke symptoms can look exactly like acute diabetic complications, so you have to do a rapid blood glucose assessment for correct triage.
And third is peripheral vascular
A
disease.
PVD, yes. Accelerated atherosclerosis in the lower extremities, leading to diminished pulses, intermittent claudication, and a significantly increased risk of non-healing wounds, gangrene, and amputation.
Therefore, management must involve aggressive risk factor reduction beyond just glucose control.
Yes. We aggressively target hypertension, preferably using ACE inhibitors. We manage hyperlipidemia, and we relentlessly counsel on MNT, exercise, and smoking cessation.
Microvascular complications result from the thickening of capillary basement membranes. Let's start with diabetic retinopathy, the leading cause of blindness in working-age adults.
Retinopathy is damage to the tiny vessels of the retina. The most severe stage is proliferative retinopathy, where new fragile vessels grow into the vitreous.
And these vessels are dangerous.
They are. They're prone to bleeding, causing vitreous hemorrhage, which presents as floaters or sudden vision loss, or even retinal detachment. The patient is often asymptomatic until the visual damage is severe, which makes annual eye exams mandatory.
Management is focused on prevention first.
Strict glucose and BP control is the primary preventative measure. Advanced cases are treated with argon laser photocoagulation to destroy the leaking vessels, or a vitrectomy to remove blood from the vitreous humor.
Next, nephropathy, or kidney disease, the leading cause of end-stage kidney disease in the U.S.
Nephropathy results from microvascular damage to the kidney's filtering units. The earliest, most critical sign is microalbuminuria, the leakage of small amounts of protein into the urine. This is a red flag that requires immediate intervention.
What is the cornerstone of management besides glucose control that protects the kidneys?
The cornerstone is the use of ACE inhibitors, or ARBs. These medications reduce blood pressure within the glomerulus and reduce microalbuminuria, providing powerful kidney protection even if the patient is only borderline hypertensive. They also require a low-sodium diet and careful avoidance of nephrotoxic drugs, including contrast dye.
Let's move to diabetic neuropathies, which affect nerves across the body, starting with peripheral neuropathy, which primarily affects the feet.
This typically presents symmetrically in the distal lower extremities. The initial signs are paresthesias, tingling, burning, often worse at night. As it progresses, the patient loses protective sensation, developing numbness, decreased proprioception, and decreased pain and temperature sensation.
That loss of sensation is the disaster waiting to happen.
Absolutely. Undetected injuries, falls, and joint deformities, which we call Charcot joints, are the result. Management focuses on strict glucose control and pain management, often requiring medications like gabapentin or pregabalin.
Autonomic neuropathies are system-wide. Name a few examples and their impact.
They range widely. Cardiovascular issues like orthostatic hypotension and silent MI. Gastrointestinal issues include delayed gastric emptying or gastroparesis, which causes early satiety, bloating, and critically wide, unpredictable blood glucose swings because food absorption is so erratic.
And renal and bladder issues.
Yes, urinary retention and neurogenic bladder, which increases UTI risk.
Finally, we revisit foot and leg problems, shown in Figure 46.3, which is the leading cause of amputation. This is the culmination of everything going wrong.
It's the perfect storm. Neuropathy causes the injury to go unnoticed and also causes a loss of sweating, leading to dry, fissuring skin. PBD means poor circulation, leading to poor wound healing. And immunocompromise means infections spread rapidly.
Let's end this section with the mandatory high-stakes patient education. The foot care tips from chart 4611. What are the 3 most important things a patient must do every single day?
Number 1, daily inspection. Use a mirror to check the bottoms and all surfaces of the feet for any blisters or lesions.
2,
2, washing and drying. Wash in warm, not hot, water and dry meticulously, especially between the toes where fungal infections thrive. Then apply lotion to the tops and bottoms, but never between the toes.
And number 3, protection.
3, protection. Always wear shoes and socks. Never walk barefoot, even indoors. And they must have a podiatrist care for calluses or thick nails, never attempting self-treatment.
Let's cover the final special issues, starting with the patient undergoing surgery. Chart 4612 outlines the preferred perioperative management, which is essential because physiological stress increases glucose levels.
Right. The risk is both DKA in type 1 or hypoglycemia if the surgery is delayed. The preferred management is to withhold subcutaneous insulin on the morning of surgery. unless their blood glucose is high, and instead control glucose with a continuous 5e infusion of regular insulin and dextrose, adjusted hourly based on frequent checks.
And the transition back to subcutaneous insulin post-op has to be timed meticulously.
Yes, subcutaneous insulin has a longer onset of action than IV insulin. Therefore, the long-acting or basal subcutaneous dose must be given approximately 30 minutes before the IV insulin drip is discontinued. This overlap is mandatory to prevent a rapid, dangerous return to hyperglycemia.
And metformin has to be stopped.
Metformin is also typically stopped 24 to 48 hours before surgery.
Managing the hospitalized patient is challenging because routine changes and medications often cause wide glucose swings. What are common causes of hyperglycemia in the hospital setting?
Well, beyond the obvious like infection or stress, causes include medications like corticosteroids, IV dextrose administration without matching insulin coverage, or just poor timing like administering short-acting insulin after rather than before a meal.
And what causes hypoglycemia in the hospital?
A huge risk is the overuse of sliding-scale regular insulin as a correction without adequate basal insulin coverage. Also, a lack of dosage change when the patient is made NPO, or simply delayed meal trays after rapid-acting insulin has already been administered.
So the nurse has to be vigilant with dietary changes.
Absolutely vigilant regarding dietary alterations like NPO status or tube feedings. For type 1 patients who are NPO, basal insulin is always required, along with IV dextrose, to prevent DKA. For tube feedings or TPN, insulin doses have to be adjusted frequently every 4 to 6 hours to match the continuous carbohydrate load in the formula.
A final word on gerontologic considerations where the focus shifts slightly to independence.
For older adults, the goal is less about hitting a perfect A1C and more about quality of life and maintaining independence. Barriers like vision loss, memory deficits, and decreased dexterity are rampant.
So you need to adapt your teaching.
Simplified instructions and devices, pens, syringe magnifiers are vital. And again, the safety alert. Hypoglycemia is extremely dangerous in the older adult due to the risk of falls and confusion, which makes frequent eye and foot assessments crucial for maintaining their self-care capabilities.
This has been an incredibly detailed and essential deep dive into diabetes management. We covered the 3 pillars of treatment, MNT, exercise, and medication, and clarified the life-saving differences in triage and management between DKA and HHS. The role of the nurse, particularly in meticulous assessment and comprehensive practical education, is clearly paramount.
If you take one idea away from this, I want you to reflect on the direct, powerful link between simple nursing education and long-term outcomes. That continuous vigilance in teaching a patient to perform a daily foot inspection or to understand the SMBG effect is what translates directly into saving a patient's limb or their sight a decade down the road. That foundational knowledge is the definition of quality, proactive clinical care.
A powerful thought to end on. Thank you for joining us for this crucial deep dive. We hope you feel thoroughly equipped and ready for your next patient.